Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor.
What's your problem?
I'm getting acne from continually washing the area around my chin, right temple, and left temple, and the condition is still worsening.
What's your age?
19.
How old were you when you started your period?
Well, it was when I was 13.
And can you describe the length of your cycle?
Once in 24 days, and it lasts for almost 6 days.
Would you describe the flow as light or thick?
It's light.
Do you use any medication?
Yeah, I take the oral contraceptive pill.
Are you allergic to any drugs?
Yes, allergic to penicillin. I feel difficulty in breathing.
What are the medicines you are taking?
Alisi 28, 20 mcg, 0.10 milligram tablet.
Is anyone in your family prone to any disease?
Yeah, my mom has stress disorder and anxiety.
Do you smoke or drink?
I don't smoke, but I drink socially.
You drink caffeine?
Yeah, 4 servings a day.
Your diagnosis report shows you have symptoms of periodic reddening of face, acne problems, and allergies. And a diagnosis of epicrine and apocrine glands shows no evidence of hyperhidrosis, chromhidrosis, or bromhidrosis. But your face shows keratotic papule. I would suggest you go for antibiotic therapy. Take a tetracycline, 250 milligram capsule. I would also suggest you take an oral antibiotic therapy with doxycycline, 100 milligrams a day.
Doctor, why does the acne occur?
Acne is a skin condition that happens when your hair follicles become clogged with oil and dead skin cells. It often results in blackheads or pimples, whiteheads, and often appears on the face, chest, forehead, chin, shoulders, and upper back and shoulders. Acne is most common among teenagers, like you. The androgen hormones increase during puberty, causing the sebaceous glands to enlarge and secrete more sebum. Hormonal changes during pregnancy and the use of oral contraceptives also impact sebum secretion. Moreover, low amounts of androgens circulate in the blood can still worsen acne. Medications such as drugs containing corticosteroids, testosterone, or lithium worsens the disease.
Which food should I avoid, doctor?
Certain dietary factors, such as skim milk and carbohydrate-rich foods such as bagels, bread, and potato chips, worsen acne.
Can you recommend any effective foods for acne?
You must stop eating processed sugar, caffeine, dairy products, and processed foods. And you should include foods that are rich of antioxidants, anti-inflammatory compounds, and other acne-fighting nutrients. Foods such as blueberries, sweet potatoes, green tea, carrots, cilantro, spearmint, oats, apples, barley, and mustard greens.
Okay. Thank you, doctor.
Thank you.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning.
Good morning. What's your problem?
Well, I have a headache and pulsatile tinnitus. For the past 3 months, I've been getting severe headaches, and almost daily. I'm getting pulsations in the head with heartbeat sounds.
Exactly at which point of your head do you feel pain?
On top of my head.
Are you getting nausea or vomiting associated with the headaches?
No, doctor.
Is there any previous history of headaches?
No, doctor. But apart from last 3 months.
What's your age?
44, doctor. When I speak on the phone, I get weird sounds in my left ear. I get pulsating sounds only in left ear.
When did this problem start, actually?
Well, actually, the ear pulsations began following a flight trip to my native place.
Is there any drop or change in hearing?
No, doctor. But I had dizzy episodes in the past with nausea being imbalanced at times.
Is there any change in your vision?
No, doctor.
Well, do you smoke or drink?
I do not consume alcohol, but I used to smoke 1 pack a day, and now I have completely stopped it.
Have you had any previous illness or surgeries?
I had skin cancer on my arm and back. I am a kidney donor, so I had a left nephrectomy, C-sections, mastoidectomy, laparoscopy, and temporal arteritis.
What medications are you taking?
Tylenol, Excedrin, and a multivitamin and probiotic.
Are you allergic to any medicine?
Yes, to codeine and penicillin.
Tell me your family history of illness.
Well, my father has a cancer, hypertension, and heart disease.
Your physical examination shows your blood pressure at 120/78, pulse 64 and regular, and the temperature is 97.4. Cardiovascular test shows regular heart rate and rhythm without murmur. There is an old mastoidectomy scar on your left ear. Weber exam is midline. Grossly hearing is intact. You have pulsatile tinnitus. Left ear with eustachian tube disorder as the etiology. There's also a possibility of normal pressure hydrocephalus, deviated naval septum, dizziness, probably due to possible Meniere disease. I would recommend you to start a 2-gram less sodium diet. I am ordering a carotid ultrasound study as part of the workup and evaluation. Since your disease is related to eustachian tube, I'm prescribing Nasacort AQ nasal spray, 1 spray each nostril daily. You use the hearing protection devices at all times. I will recheck you in 3 weeks. If the pulsatile tinnitus does not improve, then I would recommend other treatments, including myringotomy or ear tube placement. You have to undergo for an audio and tympanogram prior to the treatment procedure.
This is the end of Part A. Now, look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete the answers as you listen to the audio. Now look at question 25. You hear a physician explaining to his nurse about skin cancer. Now, read the question. Skin cancers are caused by the abnormal cells that are capable enough to invade and spread to other parts of the body. Generally, skin cancers are classified as melanoma or non-melanoma skin cancers, such as basal cell carcinoma and squamous cell carcinoma, in addition to less common types of tumors, such as Merkel cell carcinoma, lymphomas, Kaposi sarcoma, or hair and sweat gland tumors. Skin cancer symptoms include alterations in the appearance of a mole or spot on the skin, or the developing of a new spot or lump on the skin. It may also cause symptoms and signs such as itching, skin ulcerations, scaling, swelling, or bleeding, etc. Question 26. You hear a physician explaining to his patient about depressive disorder. Now, read the question. Depression is a sickness involving the body, thoughts, and mood that severely impacts the way a person sleeps, eats, behaves, and the way one feels about oneself. Depressive disorders are categorized by pervasive mood swings that severely affect all aspects of an individual's daily activities. A depressive disorder is not just a mood swing, but it is more of a case of persistent sadness. Certain symptoms of depression include feelings of worthlessness, helplessness, hopelessness, guilty feeling, lack of interest, irritability, loss of appetite, loss of energy, self-loathing, sleep disorders, etc. Question 27. You hear the discussion of 2 doctors about the frailty score concept in age patients. Now, read the question.
Doctor, should frailty be considered before any operation in an older person?
Frailty is not just a phrase, but a health metric that should be performed before the surgery to any older person. I think the frailty score is a very good concept. It may dictate the objective of the surgery. The frailty score concept relates to the inexorable decline of physiological reserve that is a normal consequence of the aging process. We must consider that a healthy 60-year-old will not be as fit as a healthy 40-year-old individual. When faced with the necessity to have surgery, the frailty concept really is more objective. Frailty can be simply evaluated with a walking test, such as a very slow walk speed or an inability to walk very far, giving a good approximation. Both patient and loved ones should consider the consequences of surgery before the procedure begins, especially in the frail. Clonus is a neurological condition that is suffered when the controlling nerve of the muscles are damaged, causing involuntary muscle contractions. Often clonus spasms occur in a rhythmic pattern. Symptoms are very common in a few muscles such as knees, ankles, wrists, calves, jaw, biceps. Damaged nerves results in misfire, leading to muscle tightness, involuntary contractions, and pain. Clonus causes a muscle pulse for an extended period that can result in muscle fatigue. Question 30. You hear the discussion between two doctors about how to cope with delirium in patients in ICU. Now, read the question.
Doctor, I feel that a solution should be devised to cope with delirium in patients in ICU. What do you think?
Haloperidol has been used for a long time in patients in ICU in an attempt to prevent delirium, a very severe and sometimes persistent acute confusion. According to a recent study, haloperidol is ineffective. Delirium is extremely prominent since it's strongly associated with cognitive impairments for a long term. Significantly, medications are the means that patients approach often. However, unfortunately, it's demonstrated that medications aren't the right approach always, or at least the haloperidol. Nevertheless, for delirium, there's not going to be a miracle in terms of medications.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36.
You hear an interview with a health administrator called Dr. Marvin Lee discussing an article about delivering high-quality non-visit care.
patients are increasingly seeking to have their healthcare needs met without coming into an office, and there's a strong possibility that non-visit care will become the rule rather than the exception. I'm Jan Dean, and my guest today is Dr. Marvin Lee, co-author of a recent Perspective article about strategies for delivering high-quality non-visit care. So, Dr. Lee, what do you think that the transition to non-visit care systems will look like?
Well, I actually think you'll see a variety of responses. Existing medical institutions will pilot and are piloting these programs and gradually scaling them up. And at the same time, of course, new organisations are entering the market and changing practices, changing how things are done. So I think it'll be a mix of both of these. And really, my sense of this is that it first has to start with culture, developing a culture for non-face-to-face medical care.
Oh, I see. Could you say just a bit more about what you mean by culture here?
So what I mean is, if you create a culture in an existing medical organisation where an in-person visit is viewed as what you do after you have tried in a very safe and highly effective way to meet a patient's need remotely, I think this will change the game for how generally your organisation will think about the practice of medicine. I do think that we'll see some existing organisations differentiate and make that leap over, yet some new organisations will perhaps be at the advantage of being able to start from scratch. So I think we'll see a blend of these two responses.
I see. So you say in the article that the goal of a non-visit based healthcare system would be to bring as much of the care and social support as possible into the patient's home. Does the technology exist to do that today?
I think in many instances, yes, and the technology is really getting better. I think it's important to reflect on how things like smartphones, particularly in the last decade or so, have influenced our expectations. There's been a massive shift in how people in everyday life think about this and about how they expect to engage with services. So we really have to find a way to map onto that consumer demand. And I think for a lot of the basic medical needs that people have, the tech is there already.
So what kinds of things do you mean?
Well, if you look at clinical protocols for primary care, these are designed to help physicians and clients make decisions about appropriate healthcare for specific circumstances. I think you can quite likely do a lot of that very safely digitally before you even consider meeting face-to-face.
But what about the times when a patient really has to be there in person?
Well, of course there are still those moments, but I think it's more about when that necessity arises. Is it earlier in the process of care or later? And what impact does it have on the patient involved? I think there are smart ways, when you do need in-person visits and interactions, to structure those so they have the least burden on the patient as possible.
Could you give an example of what you mean?
Well, one example we mentioned in the article is a scenario when a person has to provide a blood specimen or urine. They currently do need to be in person, but instead of building up an incredibly expensive office and lab infrastructure around a city, you could build up a very small collection of centres that would be cheap to operate. The patient could simply drop the specimen at the collection point nearest them, for it to be forwarded to a lab, minimal fuss, and wait for the data you need. So you can accommodate these face-to-face moments efficiently.
Finally, how can organizations go about trying to transition towards models that deliver high-quality non-visit medical care?
In time, as the technology and science gets better, gets more precise, organizations should just look at these situations that require in-person attendance by the patient and evaluate them, and evaluate that requirement against the currently available technology to see if it's something that could be safely transitioned to an online remote system. I think it's important to really critically evaluate every moment that someone has come in. And I think that if you do that, you'll start to see clear opportunities to reconfigure your care pathways quite dramatically.
Extract 2. Questions 37 to 42.
You hear an interview with a public health researcher called Dr. Pauline Davidson discussing research on a secret safe injection facility in the United States.
Okay, my guest today is Pauline Davidson of the University of California. Dr. Davidson is here to discuss the findings of two studies that focused on the effect of a secret safe injection facility in the US. Dr. Davidson, thanks so much for agreeing to talk with me today. So, what was your big takeaway from your research?
One of the things people have said about opening safe injection facilities in the United States is that the US situation is fundamentally different from that of other countries where it's being used successfully. It's an argument that just because it can work in Europe or Australia or Canada doesn't mean that it'll work here. The big takeaway from this research and all the data we have so far is that these kinds of facilities have a similar effect here in the United States as they do elsewhere. They reduce harms associated with drug use, and they reduce social nuisance associated with drug use in the same way they do elsewhere. Basically, anywhere that you have a concentrated street-based drug scene involving a lot of fairly impoverished people using drugs, you get the same set of problems, and the people using drugs have the same set of problems. And these facilities deal with them quite well, whether they're in Vancouver or in Los Angeles and Skid Row, or any other area with a lot of drug use anywhere.
So, how did staff get this secret facility going?
This is an organization that was providing other services to drug users. They were in this really frustrating situation where they had a lot of people they provided services to who were dying of overdoses. After looking at safe injection rooms and how those work elsewhere in the world, they realized that if they waited for advocacy to legalize these facilities in the United States, all their people would be dead. So, after a good deal of discussion about it, they decided to implement something along these lines. Initially, they started by re-equipping their bathroom, so it was better suited to safe drug consumption. But that had too many logistical problems. They couldn't use the toilets because drug users were in there. They had a spare room available, so they refitted that. They modeled it after the Vancouver facility and opened their doors to a group of their longer-term users, and continued ever since.
What actually happens? How do they ensure safety and that kind of thing?
Well, it looks pretty much like an ordinary clinic. It's a fairly large room with 5 separate stainless steel injecting stations, and the staff are always in the same room as the clients. People come in, do a check-in on a laptop, sit at an injecting station, and prepare and then use their drugs. Then there's a couch if they want to sit there and wait for the immediate effects of the drug to wear off. The staff are trained to use naloxone and, if necessary, call 911. And since they're in the same room, they observe people injecting, and if they see some injecting practices that are less than ideal from a public health point of view, there's an opportunity to talk about that. So there's a number of benefits to having a staff member in the same room, rather than just overdose prevention.
What do users like about the facility?
Well, the biggest one that they kept talking about is how they're able to get out of the public eye, take their time, and use in a clean, well-lit space. People talked about using in the public eye and shooting up in a hurry between 2 cabs in the streets. They were very much aware of passers-by, not just because it's illegal, they're aware of the police, but because they're aware that it's not seen as a nice thing. They're particularly terrified of being seen by someone's children. So being able to get out of the public eye was very much a relief. So there's a serious benefit to their well-being, how they feel about themselves.
Did users have any complaints about the facility?
Mostly that it wasn't open 24/7. They really liked the space, and they would like it to be open far more often. A couple of them also talked about the problem of how the organization couldn't closely coordinate or do referrals to other agencies because they were trying to keep this all on the down low. Users were quite aware of this. They were saying it would be better if this organization was really closely coupled with a treatment agency, and that handoff could be much better. The staff were also quite bothered by the fact that they had to keep the facility to a fairly small number of people and felt like they had to exclude people with mental health issues because they felt like including them would be more likely to lead to disclosure to third parties. So the organization couldn't serve a number of people who were likely at a higher need.